Hello, and welcome to the ECG 5-Minute Consult from GEMS. My name is Jonathan, and in this series I will be guiding you through the interpretation of GEMS' ECG of the month. We hope that this format will serve to be interactive in order to help you learn, retain, and then be able to utilize this knowledge in the field. For each ECG, we will be performing what we call a primary survey, in which we address 4 crucial questions in regards to interpretation. Is heart rate too fast or too slow, causing cardiovascular instability? Is rhythm supraventricular or ventricular? Are ST segments consistent with ST elevation myocardial infarction STEMI or non-ST elevation myocardial infarction NSTEMI? And are T waves consistent with STEMI or NSTEMI? It's important to have this kind of uniform, organized approach to ensure that you do not miss any findings immediately life-threatening to your patients. All other detail will be considered secondary survey items to be addressed after the primary survey has been performed. At the end of this segment, we'll present you with a multiple choice question for you to answer, and after revealing the correct choice, we will then give a brief discussion on the teaching point of the lesson. Let's get started. You arrive on scene to find a 63-year-old female complaining of weakness, which came on gradually over the last couple of hours while she was cleaning her house. She denies chest pain, shortness of breath, recent illness, or sick contacts, but does endorse fatigue, nausea, and epigastric discomfort. She has a history of type 2 diabetes and hypertension. She states that she is active and otherwise healthy. So what is the next best step? Knowing that females, diabetics, and elderly patients can sometimes present with atypical symptoms of myocardial infarction, you obtain an ECG that is shown here. Let's start by going through our primary survey. First, let's look at the heart rate. The heart rate on this ECG is 47 beats per minute, which is bradycardic as it is below 60. Now we need to ask ourselves if the patient is stable or unstable. But to answer that question, we need a little bit more information. So let's get a set of vital signs. This patient's blood pressure is 108/78, heart rate of 47, respiratory rate of 18, temperature of 98.4. They're alert and oriented to person, place, time, and their skin is warm, pink, and dry. So what do you think? They are in fact stable, at least for the time being. They could be considered unstable by ACLS guidelines for bradycardia if they were, for example, hypotensive, altered, showing signs of shock, etc. So now let's move on to assessing the rhythm. When we look at the rhythm, we need to assess whether its origin is supraventricular or ventricular. And why does that matter? It's because ventricular rhythms are inherently unstable and may deteriorate into sudden ventricular fibrillation or even asystole. There are some supraventricular rhythms that are dangerous if sustained, but they're usually nowhere near as volatile as a ventricular rhythm. But how can we tell where this rhythm is coming from? Well, we can make this quick determination by assessing the QRS complex to see if it is narrow or wide, and it's as simple as that. A QRS of less than or equal to 0.12 seconds is considered narrow, i.e. normal, and would show as a QRS that is less than 3 small boxes wide, while a QRS greater than 0.12 seconds is considered widened and would show as a QRS complex that is abnormal, that is wider than 3 small boxes. Now, the graph lines on ECG machines aren't always as prominent as we would like. In this example, we can make out the large boxes, but we'll have to visualize the 5 small boxes that make up each large one. Here's a graphic to help remind you of the relationship between the large and small boxes. And here are 2 not very good drawings that I made to demonstrate the difference between narrow and wide. And if we compare that to the QRS complex in our ECG, we can see that this QRS complex is definitely less than 3 small boxes wide, which is narrow, which means that this rhythm is supraventricular. Now we will look at the ST segments to see if they are normal or abnormal. Normal ST segments should fall on the baseline, aka the isoelectric line, while abnormal ST segments may be elevated or depressed, falling above or below the baseline respectively. If we look at our ECG, we will move through all the different regions here, taking a look at each one of the ST segments. And we can tell that on our ECG, the ST segments are isoelectric following the baseline, i.e. they are perfectly normal. For the last part of our primary survey, let's look at the T waves. The T waves should be upright in all leads except for AVR and V1. Symmetric T wave inversion greater than 3 mm is considered abnormal, and if it occurred in 2 or more contiguous leads, that would be very concerning for a STEMI or an NSTEMI. Here we see unremarkable T waves. All are upright except for in AVR and V1, which is where they are supposed to be inverted. So these are normal T waves. From our primary survey, we were able to determine that this patient has a bradycardic supraventricular rhythm with unremarkable ST segments and T waves. Therefore, this patient has sinus bradycardia. But now that that has been determined, we need to stop and make a decision regarding our patient's care. For this patient, what is the most appropriate next best step? A. Administer atropine per ACLS guidelines. B. Call in a stimulant to the base hospital. C. Review current medications. D. Give sublingual nitroglycerin. Or E. Immediate transport with lights and sirens. The answer is C. Review current medications. Let's take a look at this patient's medication list. She is taking atorvastatin, nebivolol, insulin glargine, and metformin. Do you see now why it's a good idea that we check the medication list? This patient is taking nebivolol, which is a beta blocker. One of the effects of beta blockers is to inhibit sympathetic stimulation of the sinoatrial node, which is the part of the heart that acts as a pacemaker. Dampening that stimulation leads to a slowing of the heart rate. This explains the heart rate of 47 with no ECG changes indicating ischemia or infarction. Well, that's it for today. Be sure to tune in next month for another ECG 5-minute consult.